So which of these primary impairments are legitimate for consideration within a Glasgow Outcome Scale rating?
Can you repeat the question again?
Repeat the question?
Yeah.
Sure. So which, when you look at these, the impairments that are derived basically in terms of motivational impairments, along these lines, or executive dysfunction or memory dysfunction, which of those would be legitimate for inclusion when you're considering a Glasgow Outcome Scale reading? All of them? If they're related? Okay, so you modified your answer. So the first answer was all of them if they're related to the motor vehicle accident. So who agrees with that one? Okay, the first answer was that any of these can be considered in terms of the Glasgow Outcome Scale rating as long as they are materially related to the motor vehicle accident. So who would agree with that one? Boy, you guys are improving, wow. So the second answer was all of them if they were grounded in brain injury related to the motor vehicle accident. Yes?
Even the depression?
Okay.
Yeah.
Okay. So let's go through, so first of all, the depression. Who says the depression is fair game? Okay. So you're saying basically the brain injury has caused depression and the brain injury was caused by the accident, therefore you can rate it in the GOS. Right?
Yeah.
Okay. So this is, there are two answers for this. Okay, so do you want to be picked on again? Do you mind? What's a, don't know your name yet.
Shane.
No, sorry, beside you.
Oh, sorry, Paul.
Paul? Okay, so Paul, do you want to be picked on here? Do you want to? Okay. So can you imagine a scenario where major depression would be legit for inclusion and another scenario where it would not be legit for inclusion relative to brain injury?
It would be legit if it was an organic mood disorder.
Okay.
It wouldn't be if it was, for lack of a better term, a reactive kind of depression that develops as a result of defined functional limitations.
Okay. Okay. So your first answer I'd agree with 100%. The second answer is it's not a clear-cut response. So let's say you have somebody whose major depression is predominantly an emotional reaction to their cognitive dysfunction. So you interview them and they're upset because they don't go out to parties anymore. They are socially withdrawn even from their friends because they feel that intellectually they can't, they can't keep up anymore. They can't do their kids' homework anymore because of their cognitive dysfunction. Their relationship with their spouse isn't the same now because the spouse is carrying more weight because they don't have the cognitive capacity to contribute to the marriage, to the household in the way that they did before. So it's secondary very clearly to the brain injury. So should that be included or not included? Who would say that should be included? So most people say it should not be included? No? Okay. I've personally taken the position that it should be included because I can say it's materially stemming from the brain injury. Contrast that to somebody whose major depression is more because of their MSK injuries. I'm upset because I can't get down there and play with my kids. I'm not able to take care of my home in the same manner. I can't clean. I can't physically maintain it. I can't play tennis anymore. I can't go back to my very physical job. They might have a brain injury, but their depression is more grounded in their MSK consequences than the pure consequences of the brain injury. So I say it's open question right now because we don't have an answer. This would be the kind of answer that ultimately would have to be decided by case law. So personally, I would defer to it, but you have to be comfortable with that decision. So either one, it could be right. We don't know. We'll eventually be told which is right. So it's a clinical judgment at this point in time. The key thing is, for the psychologist in this situation or psychiatrist in this situation, we have to make our argument. we can basically take either position, but we have to be clearly articulate why we made that, say that. So for me, I would say that, I would explain the reasons why the depression is very much grounded in a reaction to the brain injury. And another psychologist might say it's reactive, and yes, it's reactive relative to the brain injury, but I feel that the GOS really is strictly about the organic solely, not the next level out from it. What about pain disorder? Is there such thing as an organically based pain disorder that's rooted in brain impairment? Let's pick on the neurologist now. What do you think?
Well, yes, you certainly can. You can get spinal thalamic injury,
Okay.
fatal arousal as a result of some injury.
Okay.
So yes, you can.
Okay.
But I think it's very difficult. It's so open to interpretation.
Mhm.
I find all of those so open to interpretation. I find that a very liberal, overly liberal
Okay.
approach to this, because it's so, sleep disorders. How much evidence do you need? Do you need the pulse, the sonogram evidence, or are you just going to go on the fact that the patient says, "Oh, I don't sleep more than 3 hours a day"? Chronic fatigue syndrome.
Yes.
you know,
Yes.
Everybody comes to know
Right.
to say it's the fatigue.
So my perspective is that in terms of the pain disorder, as a psychologist, I mean, I think it's that different as a neurologist. If you were to find and feel that when you do your neurological examination, and then you feel it really coincides with a very specific spinal thalamic disorder, that's you. I would never feel comfortable as a psychologist making that leap. We're more along the lines of a pain disorder with psychological factors and associated general medical condition. But as you're suggesting, even with your level of training and knowledge, it's a challenge for you to even state for sure which type of pain disorder it is. And we know that the literature would suggest that there are way more kind of MSK-based chronic pain disorders than there are disorders grounded in a specific CNS disorder. So you might feel less comfortable going that route. Again, it's all a question of, if you're going to make these claims, you have to provide your rationale and support your position. In terms of sleep disorder, again, I would tend to agree. I think there are very few clear-cut organic sleep disorders. When you interview patients well, you'll find that, again, pain interferes a great deal with sleep, anxiety, nightmares interfere with sleep. So it's very rare. If you had evidence of a sleep apnea, and you felt that because of the sleep apnea, there was a substantial impairment in terms of daily living, in terms of like an amotivational syndrome, then you might go there. Would you feel comfortable with sleep apnea?
Yes.
Yes. Yeah. Okay. Chronic fatigue syndrome, again, I don't think there's much basis. They're oftentimes overlapping with many psychiatric, psychological conditions, and I think it's considered to be more of a rheumatological kind of diagnosis than neurological diagnosis if you're going to go the medical route. So I would, again, agree that that wouldn't be one of those areas. Any argument?
Well, I have had clients with brain injury where they lack awareness, and when you look at the musculoskeletal injuries, they may be a pedestrian, they were hit, they were thrown, lots of fractures and so on, and then you'll get them and they'll report that they have no pain in the beginning,
Okay.
and then we sometimes then watch emerging awareness and emerging pain coming forward together.
Okay.
I know that's not very common, but
Well, oftentimes what happens is the person becomes more physically functional, and that's when
And
the
that's
awareness
when-
of pain, pain's going to be aggravated to make them more aware of it, for one thing, but also, as I say, neurologically, they may be becoming more aware because of the healing to the frontal centers allowing for that self-reflection. Right. So, but ultimately, likely, still, the pain itself is rooted more likely in MSK type of origin.